Welcome to this episode of Orthodontics in Interview. Now, it's my absolute pleasure to give you guys SANJIVAN Kandasamy. So, SANJIVAN is an esteemed academic and clinician, and I've had the fortune to have a conversation with him in the past, and I really wanted to bring him on. He's an expert on both Airways and TMD, and today's conversation is really going to gun down looking at Airways, OSA, and where does orthodontics stand in the academic literature. So, a bit of an introduction to SANJIVAN. So he qualified in 2004 from the University of Melbourne as an orthodontist. Now he then went over to the States and did his postdoctoral fellowship with Ralph Barahantz and the great Lyle Johnson over in St. Louis. He's been in private practice since 2005, has his own place since 2013. Now he's had a number of illustrious awards and positions within orthodontics. In 2013, he was a clinical assistant professor at the University of Western Australia and adjunctive professor over at St. Louis. 2014, he got the Royal College Dental Surgeon in Special Field in Orthodontics. Only 9 people in the world have achieved this award, an incredible achievement. In academic terms, he's also the associate editor of the AJODO, deputy editor for the Australian Orthodontic Journal, sits on a number of editorial boards. He pretty much does everything in the world of research and academia, including his own book on TMD and orthodontics, 51 publications, SANJIVAN, if I've counted correctly. I was getting a bit blurry last night, but that's what I counted. Incredible achievements. SANJIVAN, welcome to Orthodontics in Interview.
Thank you very much for that lovely introduction. That's amazing. Nice to finally officially meet you face to face. I want to say also we just got the times right today, so that's good. I also want to say congratulations on your podcast. I didn't really know too much about it. I've heard bits and bobs about it. Then when I looked through it all properly, it's such a great educational resource. In you speaking to everyone and getting everyone's different perspectives. So, and you do this off your own back. And I hope in the next hour or so, I can contribute to your podcast, and your viewers can learn something, hopefully.
No, thank you for the kind compliment. I get very few of them, especially from my wife. So that's amazing. Thank you so much for that. So, SANJIVAN, I'm going to get straight down to it. Airways, what got you into Airways yourself as a clinician and an academic? What led you down that path?
So in terms of Airways, look, I didn't really, originally as an orthodontic resident, I was interested in TMD, orthodontics, occlusion, pain, and I had the fortunate experience of having Ronald Roth, a master clinician, great orthodontist, come over to Melbourne when I was a postgrad, and he was a great clinician, but he had a bias where he believed that we had to introduce nathological principles into everything we did in routine orthodontic care. And that would mean, mounting all the ACAS, face bows, finding CR, all those things, right? Canine protected occlusion. So for me at that time, I was like, are we really doing enough? Are we actually doing enough? Why aren't we taking corrected tomograms and all those sort of things? And there's so much controversy in TMD. As you know, TMD is so poorly taught in undergrad. It's better now, but 20 years ago wasn't great. I guess it's still not great. And we don't know, even sometimes when you speak to clinicians, they still don't know what it is, what causes it, and how to treat it. That's a topic of another podcast, I'm sure. So I got really interested in that. And so I wanted to find out more and whether we were doing enough for our patients. And that's how I got interested in that. When the airway, around 2010, obstructive OSA started getting a lot of traction. We've always known as orthodontists, even when I was a postgrad, 2002, 3, 4, we were well aware that orthodontics combined with orthodontic surgery, bimaxillary advancement, that was usually the last stage, in a sleep patient. If everything failed, we'd do bimax surgery back in the day. Today, we're a bit more selective. We try and be a little bit more proactive. If someone really needs it, we don't put them through 20 different procedures and then get to bimax. We sometimes just get straight into it if they are a candidate for it. So that topic started getting, a lot of traction in the dental profession and the orthodontic specialty. But it kind of got the kind of traction it didn't need which was everyone started diagnosing and treating OSA, you know, and it started getting to be a little bit like TMD. So for me at that point was, okay, there's a lot of information. It's not being distilled accurately and properly to the profession, and then not accurately and properly to the public. So what is our role? You know, if there is something we can do, what can we do? Are we overplaying our role, or are there things that we can do? So that was what I was excited about. And I didn't want it to go down the path TMD and orthodontics did in the past, where we were just doing anything and everything. And OSA is a bit like that. In fact, it's like TMD on steroids. Um, and ultimately, you know, if we're doing the wrong thing, our patients are the ones that are going to be getting treatments they don't need, or they're going to be harmed for it.
And then the popularity right now seems to have just exploded. As you mentioned, it's like TMD on steroids. But if I can just describe to you the AAO, which was this summer, there were 6 lectures on OSA and airways related to orthodontics. There's a number of organizations that have been established. We've got the American Academy of Dental Sleep Medicine. We've got the UK version, British Society. There's the Australian Society, Academy of Dental Sleep Medicine. This seems to have become such a prolific field within orthodontics. Why has it become so noticeably vocal or visible as an aspect of orthodontics?
I think I think it's because we understand it. I mean, the medical field, the sleep field, it's quite young. You know, 80s, 90s. You know, it really is something that evolved quite late compared to all the other medical specialties. And especially in the last 20, 30 years, a lot of research has gone into sleep medicine. That's why it's evolved so rapidly. And as a result, technologies improve. So we're starting to be more aware that sleep has its benefits, and people not getting enough sleep, their quality of life is significantly compromised. And so by that's why we're so interested in it. You know, I mean, that's ultimately why we're hearing about it all the time. You know, we're talking about, you know, I think in the past we said we were more aware about adults. We said, you know, we thought it was just an adult problem. Adults get OSA, it's because you're obese. That's why, you know. And then we appreciated that, you know, there are craniofacial characteristics that contribute to OSA. And then we realized that it's not only craniofacial characteristics. It's so multi-layered. There's so many complexities associated with it. So there are non-anatomical factors that also contribute to OSA. Then we evolved to now, hey, you know, if these people as adults are getting it, can we do anything before they get it, like preventative measures? And then we started appreciating kids can get affected too. And we don't want to miss out on helping people who are suffering a lot earlier on. And if there is something we can do, why don't we do something about it? And that's probably where the controversy starts now, because um, with, you know, every specialty wants to get involved, and as orthodontists we're thinking, okay, look, we're seeing kids early. um, is there something we can do? And now everyone's saying there's all of these things we can do, and that's why it's so controversial, right?
Yeah. So let me pick you up on that one, Sanjivan. Let's get straight down to expansion. And this is probably the topic which is the most described within the benefits of orthodontics to obstructive sleep apnea. And we've got a range of literature out there which essentially directs us towards the airway dimension increases, the reduction in nasal resistance through maxillary expansion. And we've got research coming from Zhao in 2019, which shows with using MSE or maxillary expansion, there's a 11 to 23% reduction when it comes to nasal resistance and an increase in airway volume. We've got a classic study from Sistoli in 1998 showed that AHI, apnea hypopnea index, the marker for obstructive sleep apnea, can be reduced by 12 points with the use of expansion. Why is there such a controversy over this topic of expansion and airways?
Man, that's a massive question. Okay, let's break it down to expansion, right? Because it's all about expansion. And if we look back, we just separate the OSA part for a second, and we look at, as a specialty, we've never actually agreed on when to expand and what to expand with. Let's be honest, right? Because if you really think about it, what's our criteria for expansion? If we lined up 1,000 orthodontists, you'll probably get 20 to 30 different criteria for why they would expand in a case, right? At one end, these clinicians will say, I expand in every case, okay? And then on the other end, there's clinicians that will say, no, I only expand when I see a bilateral posterior crossbite or a unilateral posterior crossbite with a functional shift. Okay. There are some would say, you know what I do is I measure the intermolar width. And if it's short, then I expand. If it's too big, then I leave it. Or some guys will say, you know what, I've been in practice for so long, I just eyeball it. I just look at there from the other end of the room, and if the maxilla looks narrow, it has a V taper, it'll need expansion. So depending on which criteria one uses, that's already a huge controversy, right? What's our criteria? Because you could go into the clinic and you'd see that as postgrads, as you see that even in meetings. Some guys are expanding when other clinicians in the room will go, did it really need an expander, right? So that's a problem. Then on top of that, while all of us are talking about the expansion, the extreme guys, and we've seen that, I won't bring any company names into it, they're clinicians that say, you know what, we don't use expanders. We have slippery brackets and slippery wires. And when I use that, the arches develop, and I have a biological harmony with the tongue and the cheeks and my toes and my neck and whatever, right? What does that even mean? Okay. How am I cranking the palate with, all of these with RPEs, and the next guy down the road is just doing it with just some brackets? So that's another controversy, right? And I always wonder, we're orthodontists, we're specialists, and every specialty has their differing opinions and controversies. But would you get that many differing opinions when you line up some cardiologists and ask them, how would we unblock an artery, right? It wouldn't be so diverse, I would assume. Okay. Um, and then of course, you've got people expanding. We go, why do we expand? So some people expand because they've got a transverse discrepancy. But then there's other people that would expand because it creates a little bit of arch perimeter. So they would tell everyone, I expand in all my cases and I treat non-extraction. And that's really funny because, we talk about clinical orthodontics. I've got, clinicians around me that work in many areas, dentists and whatever, and they treat solely non-extraction and with an expander and treat non-extraction. But what would they do with all those extraction cases? Guess what? They refer them to me. So I'm the extractionist, right? So they're treating non-extraction, and I get all the extraction referrals. That's
Well,
so they keep their practice clean and they can advertise as being a non-extraction dentist or whatever. But
well,
then we talk about, if you remember this back at, I mean, it's probably, it's still going on. People talk about class 2 relationship, and if you expand the maxilla, the mandible will jump forward. And then they talk about the
yes,
class 3 relationship. If you expand the maxilla will jump forward like a foot in the shoe principle.
yes.
And then we have the controversy of expanding for buccal corridors. And then, of course, we expand to, reduce the risk of TMD, muscle and joint pain, craniocervical posture, all that sort of stuff. So it's a big joke, right? That we talk about expansion doing all of those things. Two metal bands soldered or laser welded to a metal midline palatal screw has that much impact on one's health. I don't think there's an appliance out there in the world that has that is associated with so many medical or health benefits, is there? Like just a piece of metal with a screw in it. How embarrassing. What a
Yes.
load of bollocks, hey? Hey? And you know, and I sit there and I'm like, we sit there and we talk and we lament over the articles and you sit there and like, take a step back and look how ridiculous this is. You know, we haven't even got a criteria for expansion. So based on that, we now go into OSA, which is the new thing. Guess what? This little expander can now save lives and help us breathing, right? So so then that kind of puts everything into perspective. Is it because we have an appliance and we're trying to fit it into a diagnosis? Because all we have is a hammer, so all we need is to make everything look like a nail. Maybe, maybe not, right? So the studies show an improvement. So when you think about it, you put an expander in, the maxilla expands. The top of the maxilla, of course, is the base of the nose. So the lateral walls of the nasal cavity and the floor of the nasal cavity expands. So the effect in the airway, as we've seen in all these studies, right, is varied. That's one thing we know, it's varied. In some patients that there is an effect, others nothing. And in some patients, you know, like the Villa study, less under 20% of them, it got worse. So no one talks about that under sub 20%, but because we want to talk about that 80%. So why did it get worse? We don't know why, we don't know how. It's just that's what happened. So then we know when we follow these patients up, in the long term, these patients go back to almost their pre-treatment values. So clearly, there must be some adaptation, right, in the nasal cavity. There must be some sort of adaptation that's occurring in the nasal cavity that's soft tissues, whatever, um, that's making these patients go back to their pre-treatment values. So skeletally, we expand, but we also understand the skeletal relapse with expansion, dental relapse, skeletal relapse. So, hey, why don't we ask ourselves, maybe that's also what's contributing to the return to almost pre-treatment values. Not in everyone, but that's where that is. Then the next question is, how much expansion do we need to carry out to effectively have an impact on breathing, right? So we sit there and we go, we talk about that Pirelli study that you just mentioned, this Pirelli study, right? We just got to take a step back and go, when someone has obstructive sleep apnea, sleep disordered breathing, there's obstructions that can occur in the nasal cavity, the nasopharyngeal area, the oropharyngeal area. Most of the time, it's at the oropharyngeal area. Okay? We're concentrating on the nasopharynx and the nasal cavity. So if you expand the nasopharynx, great, but you're also not dealing with what is contributing to the OSA at the oropharyngeal area. Even though studies have shown that if you improve the nasal resistance in the nasal cavity, you can contribute to improvement in the oropharynx, but it's very light. But this Pirelli study that everyone keeps bringing, I think there was a paper that from the UK, Nikki Stanford wrote a little bit about. She wrote about Pirelli, you know what I mean? She talked about the study and said, it's not evidence based and there are a lot of things wrong with the Pirelli study. And in my paper, I try to give the Pirelli study the benefit of the doubt because there's no perfect study. Okay, there isn't a perfect study, and you try to give each study that actually makes it through the peer review literature some a bit of a go. You try to really weigh up the conclusions with the limitations of the study, but because they keep overplaying the results of this Pirelli study, we have to look at what they actually did. It was poorly structured, there's so many limitations, so many confounding factors. But the biggest thing is, they didn't even tell us how the patients were treated, were selected, whether they had crossbites. Oh, right. So how do you figure we're going to expand when you don't even have a criteria for expansion? They looked like they had a V taper. But I've seen patients with V taper with no crossbite. What warranted the expansion? In some patients, the first molars and the premolars were engaged, and in some, the second molars were engaged. So, okay, fine. Not standardized, heterogeneous methodology. How much expansion was carried out? So if I want to know whether expansion has an effect, why would I do 2 millimeters expansion in one person, 10 in another, and see whether that works out? It's like saying, does acetaminophen have an effect on headaches? And then giving someone 100 milligrams and someone 2,000 milligrams and saying, does it have an effect? It's not really proper science. So it's so variable. So in the long term, how do you deal with it? The other thing is, there weren't any controls, so we couldn't really compare. And so there's a study out there, and we talk about this a bit later, I think. And there is a study out there that says, if you don't carry out RME and you can get a spontaneous resolution of OSA by just watching and waiting, right? So if these RME patients didn't have a control, how do we know that they weren't going to spontaneously resolve anyway, right? So that's a bit ridiculous. That study left us with more questions, which is, how do we expand when there's no crossbite? Because as dentists, when we expand the upper arch, as orthodontists, I'm always concerned. First of all, if I overexpand the upper, I got to accommodate the lower arch to the upper. And we know we don't want our molars looking like this in the lower arch because that's not going to be stable, right? Then it's how much expansion do we need? And then the answer is vertical bite opening when you expand. So in a long face patient, do you really want to be expanding so much and creating an open bite? So you want to help these kids, but then you're also creating an open bite and the downwards, rotation of the mandible and all those sort of things. So, so, um, so yeah, I don't think it's as clear cut as expansion cures everything. Um,
Mhm.
and anyway, I don't want to put another question to that, right? Another proper way of looking at this. How many patients do we see with OSA today? Because some people don't, but adults, and think, wow, I wish I saw you when you were 2 or 3 years of age. You needed a maxillary expander, right? Hashtag never, right? It never happens. And studies have shown that the transverse dental widths of the maxilla to the mandible in OSA patients are almost the same as non OSA patients. So the
Wow.
transverse isn't an issue. So if we're going to expand, we need to know dentally, are we leaving them with a malocclusion, with the upper molars outside the lower molars? And what's that going to do to the malocclusion in the long term? It's going to cause tipping of the lower molars, the bite opening, extrusion of the upper arch. We're creating a bigger problem to fix later on.
Mhm.
No one talks about that, do they?
That's really interesting. That's really interesting insight into this one size fits all. And actually, if you look at things just with one eye closed, what is happening to the rest of the occlusion and the management of it? I want to pick you up on something there. So just to read the systematic review by Fernandez Barales in 2022, that was one that you just cited. Looked at the difference in RME and AHI, so a reduction in AHI, but also versus watchful wait, and where they did look at controls and showed there was no difference between the two, which I think is really interesting as a piece of research that there is that information out there. The idea of, well, expansion taking place, but also skeletal relapse occurring. So now with the advent of miniscrew assisted expansion, is that something that you do? Do you think that offers a resolution to this skeletal relapse as you describe it and could pave the way to have expansion involved in OSA management?
Mm. Yeah, so now this is a new appliance, right? Now we talk about RME with screws in the palate, right? And I think, I've used our MARPE several times. In fact, when they first came out, when we were in St. Louis, we tried to put screws in the palate and expand. But back in the day, mini screws were just coming out, and so we couldn't get all the fancy abutments that you can get now, and metal printers and all that. So you can't really, we don't have that luxury now. We have that luxury now. We didn't have that back in the day. But a lot of clinicians are big advocates for going into it with a MARPE. Um, so for me, I'm quite selective with MARPEs. Really, you only would consider a MARPE if the patient's skeletally mature. So you can't do orthopedic maxillary expansion, right? and you only need a little bit of expansion. But if you need a lot of expansion, I would consider a surgically assisted maxillary expansion because it's more predictable. But there are, of course, greater risks and costs associated with it. I get that, right? But and we talk about MARPE like we're going through a drive-through and ordering French fries. It's like that easy. Um, it's not. You know, it's hard work. And if we go back, every time you probably hear me going, let's go back to basic principles. When we go in and we expand in a child, we expand. We want to get a split at the mid-palatal suture. One quarter turn creates about 1 to 2 kilograms of force. Okay, whatever that is in pounds, 4 or 5 pounds, whatever, and it could be even more. And that's when the child has patent or less interdigitated circummaxillary sutures. Okay, we got that. But in an adult, these circummaxillary sutures are, well are fused, let's say, okay, are well interdigitated. So then, even if you had a patent mid-palatal suture, when you expand, these forces don't just break at the circummaxillary sutures, they basically get dissipated into the entire craniofacial complex. Oh, let's think about that. Do you think that's not a risk? God damn it,
Mhm.
it is, isn't it? It's ridiculous when we don't, and we're like, oh, let's just put some screws in because we need some expansion. I get that. I see validity in that. And superficially, it looks like a benign procedure. And then what I don't like is when people say, hey, the risks are small. If they do occur,
Mhm.
those risks are significant. They're not minor. You know, what's minor is if I put a mini screw, I'll need a buckle mini screw, I put a mini screw in there. Yeah, right. You get some inflammation, you get loosening of the screw. You might nick the roots and you get root resorption. Great. That's a small risk. No one dies. But when you actually think about the risk, the small risks of MARPE, we're talking about asymmetric expansion. Cool, no one died from that.
Mhm.
But what about tearing and fractures of bone and dropping of the eyeball? When I read that dropping of the eyeball, I mean
Yeah.
shooting pain, neuropathic pain, hearing loss, dizziness, temporary numbness, whatever. I can't remember all of it, but and then the authors dismiss as you know what, Farooq, it's temporary. I'm sorry,
Mhm.
that patient with the dropped eyeball, I don't think they're going to be comforted too much with the hey, listen, son, it's only temporary, right? I mean, that's huge. And I would only expand 2, 3 millimeters at best, but these guys are expanding 7 to 10 millimeters.
Yeah.
So my concern is, the soft tissue side effects, the zygomas, the nose, the mid face, the orbits, right? And a lot of these patients, when we see they're being treated in a university setting, so they're more acceptable of, we're getting this at which is, I mean, whether it's fair or not, they're getting it at a discount rate and they accept the risks. But in a private practice setting, in a private clinical setting, parents want something that's predictable and low risk. You can't really have patients in your waiting room with a dropped eyeball, and it's not a good look. It's not a practice builder. And so I think that we have to be, yes, MAPI is a modality that we can consider, but we have to be really selective given the risk. And we shouldn't downplay the small risk, even though the incidence is small, because even if it's small, it's extremely concerning as an orthodontist because we don't deal with life threatening situations. But when we're putting them in situations like this, I would be concerned. And the other thing is, if there isn't a crossbite and a patient has OSA and you're putting them through an MARPE, you have to ask yourself, well, the risks are small, but they're great if they occur. There's no evidence to support this expansion. Why are you putting the patient through it? So that's really, really important. But I thought about this
Huh.
last night, right? Because you asked me this question before. I thought about this last night, and no one really talks about this. And I think this is really quite pertinent to clinical orthodontists out there. I'm a patient. I've had an MARPE. My eyeballs dropped. I got shooting pain. I got hearing loss. Okay, it was temporary, lasted 6 days, 6 months, whatever. Now, getting on with my life, 5 years down the track, I'm suddenly getting impaired vision on this eye. I'm losing a bit of hearing. I started developing neuropathic pain or trigeminal neuralgia on this side. Is that clinician now liable? Is that clinician now medical legally liable for that? What is the long term responsibility and the consequences of that? Does that make sense? No one talks about that, do
Yeah.
they?
Yeah.
Because we're so excited about getting those screws in and selling those RPEs.
I think that's exactly where we are right now. We've got the new appliance. There's a degree of excitement within the profession about, as you've so eloquently said, where does this appliance fit in now to orthodontists? Fit in somewhere, and this seems to be where it is traveling towards. The oropharyngeal airway. So the second key orthodontic intervention with obstructive sleep apnea and sleep disordered breathing is the advancement of the mandible. Now, in what you've described, the majority of OSA or significant amount is based on the oropharyngeal airway. So if the mandible is postured forwards or advanced forwards with the use of myofunctional appliances, whatever format they take, whether it's the Catlin, Bionator, Twin Block, whatever it is something that Audrey Yoon described in her 2023 paper in the Sleep Journal. Now, do you agree with the principles behind this? We've got some research by Yan 2019, again showed an OHI reduction when using a twin block or a Herbst appliance. It seems to have some credence within the literature. What's your thoughts on now advancing the mandible and improving the oropharyngeal airway space?
Okay, well, there's a couple of things. So you've got the myofunctional therapy, and then of course the mandible advancement. Um, so let's talk about myofunctional therapy. Talk about myofunctional therapy. For speech, swallowing, advancing the position of the tongue, growing the mandible, correcting the growth pattern of the mandible. That's what it said in that paper. And the whole point of this myofunctional therapy is to strengthen the muscles of the tongue, the lips, and all of that, which is great. That's the basis behind it.
Yes.
Then the child falls asleep. Sleep is a state of unconsciousness. So the muscles of the face and mouth are not under voluntary control. So how does that impact one's OSA? Now, the studies show to some degree it has an impact. They have difficulty dealing with the other confounding variables and the other issues, and the studies are small, and we can talk about all the limitations, right? But let's just go with their conclusions. There's a little bit of an impact from myofunctional therapy. So my question is, first of all, in some patients, there is no control because whatever you're doing voluntarily, you have no control when you're asleep. So that's one issue. If it has an impact, the impact is small. The question is it also sustainable? They got to do this myofunctional therapy for the rest of their life, right? I get a six pack. Is that sustainable? Well, I'll tell you now, given my personality, it's not, right? And there's less chance of me getting that six pack back. But the reality is, sustainability is not what we talk about. We just talk about just put this in and hey, it's the panacea. But you have to maintain those things, right? And and that's where my functional therapy may break down for OSA. It might have its validity in during when someone's awake, like speech and swallowing and whatever. But with this OSA, I think there's a big gray area there, and it sounds
Mm-hmm.
fancy. And I think also we need to be mindful that how are you going to tell a 3-year-old to do those exercises? I mean, have you tried to manage a 3-year-old? Trying to get them to just keep quiet for 3 minutes is hard enough. You want to tell them to start doing these mouth exercises and tongue. I mean, the practical reality, the clinical application is just ridiculous. It sounds great in a paper, but the science doesn't back it up. But it sounds great to just dribble vomit, but it's just not practical in real life. Then the second part, so that's your myofunctional question. The other question was the mandible advancement. And this what blows me away, okay? Everyone goes, well, we need RCTs and then we can make a decision. Now we have low quality evidence. But haven't we worked out we can't grow mandibles? I mean, we
Mm,
talked about we have the high quality RCTs from 1998. I
yeah.
mean, 1998, what do we have? An iPod. We don't even use that anymore, right? So in 1998, we are talking about we already established we can't grow mandibles, but now we suddenly can. And not only we can grow mandibles, we can change the growth pattern, the direction, we can move it left, we can move it right, we'd shake it all about. It doesn't happen. If we could, we would do it, but we can't.
Yeah.
And and so I don't know whether there's validity in putting 2, 3, 4, 5, 6, 7-year-olds with all of these appliances when the science doesn't justify growing mandibles, myofunctional therapy, the sustainability of myofunctional therapy. The mandible's going to grow to where it's genetically predetermined to grow. You said the systematic reviews by Yan Yan and Camacho later on, their studies were systematic reviews. So they based their systematic reviews on multiple really weak studies. So if you have terrible ingredients for your soup, you're going to have a terrible soup.
Mm.
Okay? If you got good ingredients for your soup, you're going to have a nice, tasty soup. So that's what you have with those systematic reviews. And they even advised that it was weak and it was poor. They had no follow up samples. They had super small samples of 7 to 11, no controls. So based on all that, I think we have to really reel it back and say the evidence doesn't support it. And the other side will say, oh, you're claiming all of these things. You don't talk, you're not talking to the guy in the clinics and they're doing the work. But we've already established we can't grow mandibles. There's limited evidence to myofunctional therapy and the practical reality of it with managing a 2 to 6 year old and the sustainability. And for that little impact, is it worth putting those kids through all of it?
I think that's really insightful. I think it's great that you've addressed the actual topic of how the process can improve the airways and what the limitations are with respect to literature. And there is some evidence there, but it's small, it's weak. And I love the fact, and we didn't mention this in the introduction, but you're 4 days a week in clinical practice. So you're seeing patients most of your working week. And actually, how do you implement these things with patients on a regular basis, and how can that be implemented, and the challenges with it? The next controversy, I'm giving them all to you this morning, Sanjay.
You're hammering me today. I'm just going to have hate mail after this, one hate mail after another.
This is it. I can send you his email. Please don't send it to me.
Yeah.
The extractions, oropharyngeal airway space. You carry out extractions for bicuspids. You retract the dentition. You're reducing the space for the tongue, surely. The tongue is a fixed size object. It's going to go back into oropharyngeal airway space. How do we understand the description there I've given as an overview? It is what's put forwards. Surely this should result in a worsening of a patient's obstructive sleep apnea, or create obstructive sleep apnea at the least.
Yeah. I know it's a big thing. I think this is such an important question to answer because people throw that term, oh, extractions causes OSA so loosely. And they say that the tongue sits in that space, the lingual floor, the mouth, and the teeth prevent it from coming forward. And obviously, you've got the posterior wall with the posterior pharyngeal wall, right? Um, and then, but the thing is, let's look at it differently. Let's look at it as let's assume that extractions cause OSA. Let's just assume that. Let's say they're right. We know now definitively extractions cause OSA. So what do? You're going to go to work on Monday and you see teeth, severe crowding. You're not going to extract. You're going to blow all the teeth out because blowing the teeth out would assume you're going to improve the airway. Now those teeth don't have any periodontal support. They got gingival recession. They've lost bone, and the lips are out there. That's super ridiculous, right? That's a ridiculous call to make. Extractions causes OSA. Then what have we been doing? So we haven't talked about the research, we haven't talked about the science. Let's just talk about just being smart, being objective in your thought, doing your own critical thinking. So let's look back at the last 100 years, right? Have we indirectly caused all of these deaths and suffering as a result of OSA? Because as orthodontists, we're liable for those patients who have died in our own hands as a result of our extraction therapy. I don't know, that's a big call to make, right? What do the non-extraction advocates, what are they trying to tell us? Are they telling us, okay, extractions causes OSA, so we don't extract, which does not make sense. We blow everything out, which is not practical, not stable, not healthy periodontally. So it doesn't change what you're going to do tomorrow. You still have to extract. I don't see a lot of orthodontists going from here to here regularly. They don't go from their teeth. They go here. I've never seen anyone go like this, where the tongue has to scurry away down to the back of the throat and just seek refuge because it just has no room at the front. That's so embarrassingly stupid sort of logic, right? But that's how they're trying to sell us the idea. Most of the time, as orthodontists, we respect the lower incisor position as it presents itself, right? From all the studies and from the past, the Washington studies and all that, the initial lower incisor position is a good guide to start treatment from. And so a lot of orthodontists would try to respect that position and extract and maintain that position. That's why we talk about anchorage and biomechanics and how to close residual space following alignment of teeth. So that's what we're trying to do. But I think the airway advocates love to promote this idea to scare the public. So if they scare the public, they then can make their colleagues, which is us, the traditional or the classical or the old school orthodontists, look less competent, and then they can promote their own agenda, serve their financial, needs and goals, and build their practice. I think that's really unethical. So enough of my little rant. The main thing is then we look at the studies. We go back and we look at the studies. So the studies all show they look at the airway before, they look at the airway, they see very little change before and after extraction. We can talk about all those studies. Oh my God, we haven't got time, and you'll be slashing your wrists, and everyone listening to this will be slashing their wrists along with me. But you have one study, Larson in 2015, they had over 5,000 people. I mean, seriously, they had premolars extracted, no premolars extracted, followed up, and the group that had extractions had 10% of OSA prevalence incidence. The 10% of that population had OSA, and the non-extraction group had 10% roughly. So there wasn't any difference. So that cannot definitively show. But then you'll ask the airway advocates, and they're like, "Oh no, you haven't seen these. They must have done this, and they've selected this." How come they're so quick to criticize those studies, but they get their feelings hurt when we use the same template they use on us, on their studies, where n equals 4, right? We show a study of n equals 5,000, not enough, problems with that study. We talk about their study of n equals 4, and it's, oh my God, it's, we're being unfair. So I think with this whole extraction debate, it doesn't. I think people shouldn't have to even talk about this extraction issue being an issue when it comes to OSA. Have you stopped extracting teeth now in practice?
No, I'm afraid I do extract teeth still. I would say that and I think you're absolutely right. There's a caricature that gets painted, right, and maybe on from both sides. But the idea that there's an orthodontist who takes 4 teeth out and then looks at the patient, and I think for us in clinical practice, the extraction decision is a really serious decision. We don't want to make the wrong decision. It's irreversible. We also want to manage our mechanics appropriately and so forth. And everybody knows if you have too much space, it's a real challenge to then close the space and manage the case.
Awful,
So
yes.
actually, for the longevity of clinical decision making and ease in clinic, you want to make it the appropriate decision. as opposed to take teeth out and do orthodontics
I
breathing?
don't want to take teeth out. I mean, I mean, even after 21 years in practice, and I sit there and I'm like, oh, how can I treat this non-extraction? I still look at the face and how can I protect the face, and how can I, be mindful of the anterior limits of the dentition, and, be mindful of the vertical, look at what the vertical facial pattern is. We look at all of those things. And even for our more, even the more sloppier colleagues of ours, I feel like, they don't want to take teeth out if they can avoid. I've never seen an orthodontist that just is so excited to take four teeth out. And we're all trying to do it non-extraction. Yeah. And you got to rely on elastics, you got to do this, you got to do that, all of those sort of things. And so anyway, so yeah, so I think that's just another scare mongering tactic.
Yeah.
Yeah.
And I think it's great. We're in the middle of the road, not polarized one way or the other to non-extract or to extract. I think you're right. It's a complex process, involves decision making, and should be planned with due consideration. It's irreversible at the end of it. Now, the next controversy I want to discuss with you, and get your thoughts, Sanjivan, is mouth breathing. Now, again, I'm just going to go over the idea about mouth breathing being negative. And I want to get your thoughts as to where do you stand and the literature stand in that respect. So if I can just have a quotation here from Sleep. This age group, young patients, to paraphrase, it is common for the tongue to be displaced towards the oropharynx, which affects the development of the mandible. No reference. As such, it is hypothesized that if a child is mouth breathing, and lower posterior tongue posture will result in descent of the hyoid bone, which can impair mandibular growth, i.e., it stays class 2 or skeletal 2. Further studies are required to validate the tongue posture effects, which will help formulate potential clinical guidelines. Mouth breathing preventing the mandible from advancing, resulting in a reduction in airway space. What are your thoughts on that as a concept? Where do we stand in understanding the relationship to mouth breathing and this negative effect that it's been connotated with?
Yeah. The child is mouth breathing. The tongue is postured lower and forward, descend of the hyoid bone, and you impair the mandibular growth. Yes, that's the one. Pretty impressive statement, you know. And is that's sort of the Yoon paper?
That's the June 2023 paper.
Yeah. So the question is, what does she want us to do with it? Like with that statement? Do you know what I mean? So she basically wants us to get all our kids to stop mouth breathing. Then we have to myofunctional therapy to train the tongue, and then we have to put an appliance to grow the mandible, and then we can, that's really what all those things are saying, right? Um, in an indirect way, but that's what it's trying to tell us. Okay, and I'm just trying to read between what the directive there is in that sentence. Then and then we just blame it on mouth breathing, and I think it's so hard. It's so hard to simply answer that question without actually looking at where it started, and mouth breathing is a controversial subject. Chronic nasal obstruction and its impact on dental facial growth. God, you know, that's a full-on podcast on itself. But if we look at this whole mouth breathing issue, it all stems from Harvold studies out of UCSF back in the 1970s. They carried out the monkey studies, and then Linder-Aronson studies on children with enlarged adenoids, also in the 70s. It was all around that time. That was the theme at that time. And what Harvold did, let's talk about Harvold and his monkeys. Harvold got a whole bunch of monkeys, a lot of monkeys, and growing monkeys, rhesus monkeys, Macaca maluta, whatever, okay? That genus. And he plugged the noses of all these monkeys. What happened was chronic nasal obstruction in growing monkeys caused changes. Okay, vertical changes, bite changes, all of those things. But those changes were varied. It wasn't guaranteed. You weren't going to get guaranteed this much of vertical opening in one monkey and every other monkey. No, it was very different. Some didn't, some did. all those limitations aside, the biggest problem with that study is monkeys are obligate nasal breathers. They cannot breathe through their mouth. So their soft palate, their velum, locks in with the epiglottis, and they do not breathe through their mouth ever. So when they had their noses plugged, they were placed in a life-threatening situation. So for them to breathe, they didn't just, for me to breathe, do you see me go like this? I'm not doing that, right? But monkeys had to do that. To survive, they had to bring their mandible forward, they had to bring their tongue forward, they had to really exaggerate their posture to open up the oropharyngeal airway space. So we then found that out, and we know that humans don't do that. We just slightly open and we can breathe through their mouth or through our mouth. So how do you extrapolate what happens in a monkey to that's exactly what happens in a human? Because humans don't react to nasal obstruction like monkeys do. I understand some of our colleagues do carry on like rhesus monkeys, right? But the reality is they're not actual monkeys, they're humans. Their behavior might be, yes, they belong to in a tree rather than in the clinic, but the reality is they're not actually monkeys. And so we cannot make that comparison. And to to translate that is ridiculous. So the question being, the child is mouth breathing, this is exactly what's going to happen. Well, we have the monkey studies do not prove that that happens. But there is obviously something that happens when there's nasal obstruction. There is an associational relationship. Okay. So I think that's important to be mindful of, because that's where that controversy starts, and everyone keeps perpetuating this controversy over and over again. And no one really knows why. If you actually look at those sites, if anyone actually picked that study up, the Harvold papers, and actually looked at how and what they did carefully.
If I can now put forward to you another point here. So this was by Barry Raphael, who's an American-based orthodontist and calls himself an airway orthodontist. I just want to go into a little bit of detail here, if that's okay, about a child who struggles to breathe. So a child who is mouth breathing, if they are told to close their mouths, you'll see them straining to breathe through their nose. The ability to create optimal gas exchanges will be challenged or difficult for them. And it may be helpful for their growth and development if they are not struggling to breathe. And a statement from him here is saying no to that is like denying that breathing is an important thing we do moment to moment. So, in my understanding from Barry Raphael, he's describing that the difficulty in breathing easily by being a mouth breather by default and struggling to breathe through the nose does impair the body's ability to function. And if we have an ability to slightly improve it, should we not be obliged to do so to make breathing easier for these patients?
Yeah, I think that's the big misconception, right? Well, Audrey said, you said mouth breathing, tongue posture, hyoid bone, mandible. So we need to grow the mandible, we need a myofunctional therapy, we need to, okay, that's what they're saying. But I'm saying, okay, take a step back. That's an exaggerated response. And why is that controversy there, this whole mouth breathing? Then, of course, the quote that you just had of this guy, you were saying that, yes, so breathe through the mouth, can it affect our face? Can it affect our development? If we need to get the oxygen in, I get all of that. So the second part to that then is we can't go past, we talked about the Harvold study, we have to talk about the Aronson study, which is he found a bunch of kids with enlarged adenoids. So I'm going to answer that question with this study, because this is also it's an epic study. It's a landmark study that has formed the basis for so much of this controversy. We have that term adenoid facies. A patient with long face, tongue out, narrow face, because your mouth's open all the time. The theory is the cheeks go in and mold the mid face into being narrow, the jaws are being small, the palate small. Cool. And we look at the adenoid faces and said that's the result of someone breathing through their mouth. And hence why Barry, the guy Barry, has gone on about how this is what happens. It's going to, you're not taking the oxygen enough, then you look funny, you act funny, and all of that sort of stuff, whatever. And then you look at Aronson's study, and they basically came up with based on his findings, he took a whole bunch of kids, a lot of kids, and he compared, kids with no adenoids, moderate adenoids, and large adenoids, and those that had their adenoids removed, those that had recurrent infections, all those things. Interestingly, there were so many issues with the controls and inconsistencies. He measured some, he didn't measure other characteristics. So there were some problems with that. But mind you, the study was 50 years old, so we're not here to pick at it. But at the same time, we need to be mindful that you can't take certain conclusions away if the study doesn't support it. He found that in a kid with enlarged adenoids and had the least amount of nasal airflow, that those kids didn't exhibit anything like the facial characteristics of adenoid facies. Interesting, right? So that's something we don't touch on in that study. We just pick at the statistics that we need and we just go off. Then the biggest problem, like the monkeys, monkeys breathe through their nose. We don't, we do back and forth. He just looked at the kid and said, subjectively, you're a mouth breather. You're a nasal breather. Whereas the thing is, we all know you can't just subjectively tell someone you're a mouth breather, because as humans, we go between breathing through our mouth and our nose. We're never solely doing one or the other. So unless you've got chronic nasal obstruction, right, then you have no choice. But majority of us don't. We go back and forth. So I think that controversy needs to be nipped in the bud. There is an associational relationship. I think that's important to know. There is an association between total nasal obstruction and dentofacial growth. But association doesn't necessarily mean cause and effect. They happen to be there, but the questions we should be asking, I think the most important thing is the questions we should be asking, Barry should be asking rather than make comments like that, is how much mouth breathing actually affects growth. How much mouth breathing is normal because we go back and forth. And I'll say, if you look at everyone on the plane during a long-hour flight to London from Perth, are they all breathing through their nose or their mouth? Right? They're all like this. Should we all put a rapid palatal expander and during the in-flight movie tell everyone to do myofunctional exercises because when they go like this, they're going to suffer? I mean, I think, we all breathe through our mouth. We've all done that. It's not the end of the world, but the questions we have to ask ask the right questions, which is how much mouth breathing actually affects growth? How much mouth breathing is okay? How much nasal obstruction needs to occur for there to be an effect on dentofacial growth? When does this need to occur? How long does it need to occur for it to affect? Is mouth breathing actually okay? Are those cases that we're seeing that have excessive posture of the tongue and the mandible forward to breathe because there's so much obstruction? Is that what is causing this dentofacial growth aberrancy? Right? So those are the important questions. Now, so I think it's important that we deal with any pathology. So if a patient like this child he's talking about has chronic nasal obstruction, I think it's important to find out the pathology behind that. Is it chronic allergic rhinitis? Is it asthma? Is it some other problem? Is it enlarged adenoids? I think it's important to do that. I don't think it's important that we just sit there and dismiss it. The studies have shown us, Bishara's longitudinal studies, have shown us that the vertical facial pattern in 80% of people is already established by 5 years of age. Okay, that's interesting. You're a long face or a short face by 5. Now, the other guys will be saying, oh, that's because the muscles aren't strong enough and the masticatory muscles aren't strong enough, and they probably were a chronic mouth breather at 2, that's why they're a long face. Okay, studies by Prophet back in the day has shown us that the differences in masticatory forces between long faces and mesofacial patients only establish themselves from the age of 10 to 12. Where's form and function? We don't talk about genetics. Maybe it's genetics that predetermine whether we're a long face, right? So maybe all the other things come in as a result of the genetics creating the platform, right? So I don't have all those answers, but what I'm trying to do is critically evaluate what's presented to us, and then using critical thought and questioning, look at the data that we already have and see whether it supports these claims. So if the long face is already established at 5 years of age, how are we telling everyone that they needed an RPE at 9 to prevent the long face? Does that make sense?
Yeah, it does. It does. There's a gap there, isn't there? There's a gap there between those two ideas about what is the cause and what is the treatment, and actually they are not in the same space. Genetics is an interesting thing which doesn't get discussed. It's almost as though the entirety of our control as clinicians is the determinant for the patient, rather than actually having the humility to say, actually, we are one factor of a multitude that we do not influence or control, at least at this stage. So let me ask you a frank question, Sanjivan. Is an orthodontist treating patients with obstructive sleep apnea through orthodontic means somebody who is practicing unethically at this point in time?
Um, so, so the unethical part. Um, yeah, I feel, I feel like I think it's a big call to say whether someone's unethical or not. We can say where we can talk about ethics in terms of, I mean, are you ethical in terms of referring to yourself as an airway orthodontist? Are you ethical in calling yourself a sleep centered orthodontist or dentist? Is it ethical? I mean, in Australia, we have guidelines we have to abide by, what our specialty is, and we have to practice within the scope of our practice. And by dabbling in the airway or all those things, is that really going beyond our scope of practice? Does that make us liable medical legally? All those sort of things, all right? So that's an important thing. Um, but if I call myself an airway-centered dentist or orthodontist, then I have an agenda. My agenda is I'm also straightening teeth, but I'm all about the airway, right? So if you're telling the whole world you can detect and manage OSA in young patients in ways that your traditional or other old school orthodontist colleagues cannot, well, yeah, that's unethical. I think that's unethical. If you are expanding, growing mandibles, changing the trajectory of growth with myofunctional therapy indiscriminately when the evidence is weak, we've definitively shown we can't grow mandibles, then that's also unethical, right? We talk about ethics and what's ethical, what's not ethical. If you're carrying out special exams, you're carrying out cone beam CTs on every patient, you're trying to diagnose something that's not there, or you're over-diagnosing breathing issues in all children, and then you're fear-mongering all the families to come to your practice because you're the only one who can do that, provide the service, only so that you can over-service their children with treatments they probably don't need or in the long term have shown to be no benefit at all. That's also unethical. I think that's so I think we need to be mindful that how far we take this. I think we need to do something. We are aware that OSA is an issue in children, and but we also know that the extreme, uh, there there is a financial, there is they're masking themselves. They're coming across as being concerned about the holistic welfare of the patient, but really they're only concerned about it seems sometimes they're only concerned about financially lining their pockets, because what they're trying to do without the evidence, they're trying to monetize this controversy. Lyle always says nothing sells controversy like controversy, right? And doing that is unethical. And so, at the same time, they're capitalizing on this cultural shift that we've got. It's a cultural shift in the last 10, 15 years, maybe last 7 years, where we cancel anyone that speaks the truth. The truth's not enough anymore. No, we cancel everyone because the truth is offensive. I think in science, you can't be offended by doing the right thing in the best interest of your patient. We're having arguments, yes, be confrontational, because at the end of the day, the one person that we go to work for is our patient every day. We do that
Yeah.
in the best interest of that patient. So if it benefits that patient that we have an argument, we have an intellectual argument, and we come up with something that's of benefit to that child, then I think it's worth it, regardless of whether you got offended or not. An example of that is, Kevin O'Brien. I don't know him. I've never met him. I don't know him personally. Not a friend or anything. But he's a highly regarded academic. I get that. But he called out, I think, Audrey Yoon on a talk or on a paper, and he said that this wasn't right, and it was all these false claims. Fair enough. I think that was a very fair, objective way of looking at it. But he was berated for it. He was told, he stepped out of line. He had to come and apologize, I think. And I'm like, why is he apologizing? He wasn't offensive, right? And if we actually look at what was said and was in the paper, the authors knew exactly what they were writing. I'm not angry with anyone. I just feel disappointed, so disappointed that ultimately that child in the chair is going to get something they may not need, be charged for, and be inconvenienced with a certain type of treatment.
That's great, and it's a really profound answer, and you went straight to the crux of it. You remind me of a statement from Lyle Johnson, which he said, "It isn't unprofessional to question a person's science. It isn't uncollegial to demand proof, and it is not impolite to point out glaring conflicts of interest." Now, I think, as you mentioned, the truth can be harsh and difficult, but actually it should be asked in both directions. We should question the foundation principles of orthodontics if it is worthy of being questioned. And likewise, we should defend and question new treatment modalities and their applicability to science in the interest of our patients, who are ultimately the people who we serve. I'm just going to conclude with the final two questions now, Sanjivan. So the question I want to know, you've got this prolific career in academia, within the literature, you're a clinician who's innovative in their clinical practice. But who is it who you admire the most in orthodontics? Who's your inspiration in this field?
You stop hitting me with bullets now, so that's good. So we're on the social side of the questions, which is good. Geez, I can take my bulletproof vest off. Um, the Who do I admire? I mean, I've been really fortunate in the last 20 or so years to have met some amazing people, amazing orthodontists, and so many have contributed to how we do things now. And I feel like I'm a composite of the people I've interacted with, and I've taken good things that I've liked about all of them, and they've all kind of molded me to, I guess, who I am today. But three people, I guess, stand out in my mind: um, Lyle Johnson, Donald Rinchews, Chuck Green, Charles Green, and I feel all three of them have done so much in such a unique way. They've done so much for the specialty, and everyone's, a lot of these amazing academics have done so much, and clinicians have done so much for the specialty. But what's unique about them for me was the fact that they they were so adamant about telling the truth and making the specialty constantly accountable for the science. And if you can only see the impact of what people have done, only after 20 years. And they all three of them in their own way have changed how we do things. They've changed so much of how our orthodontic specialty looks at things, from TMD to class 2 to clinical orthodontics to pain, all of those sort of things. And every patient out there um, that has been treated by a clinician that's been influenced by one of those three people are better for it, you know. And that is about them as academics and clinicians. But I've been blessed to have actually met them, spent a lot of time with them, and I can genuinely say they're such loving, good people. They're honest, they're down to earth, they're very generous with their time and their wisdom. You know, I could just pick up the phone and just call them and just have a rant and listen to their rant, and it's very good. And how they've done things have always resonated with me. So I've always had that attitude of trying to make people accountable in terms of the science in clinical practice, and and it comes at a cost. You know, I've seen them. I mean, to me in a lesser degree, but them, they've taken a lot of heat for saying things that aren't popular, but it is the truth, and the truth can be offensive to many.
And then the final question is: what one piece of advice would you give to the orthodontic audience who are listening to this podcast?
Hey, by now you already know there's no one piece from me, is there? You know, yeah. But if I had to distill it to a couple of things or one thing, in two words, I'd say do better. Okay, and I elaborate on that to orthodontists, and I mean we should always strive to do better today than we did yesterday. As a human, as a husband or a father, all that sort of stuff, we should. Okay, I think that's important. But as a clinician, we should. And this ranges from looking at your cases carefully, taking good records, um, making that connection with your patients, managing your staff better, managing your practice, being more hands-on. There's no substitute for putting in the hard yards. There is no shortcut. Um, I think in our specialty, we have this misconception that we can delegate everything. you know the programs will sort this out, this will do this, the hygienist will finish that. But how's that worked out for us? It hasn't worked out for us as a specialty very well. And in real life, when you take your eyes off the ball, it's off the ball. It's the reality, right? You don't have your hands on it. When you don't have your hands on it, it's over. And you have a highly grossing practice doesn't necessarily equate to um, amazing successful outcomes. And that is that balance. You take that cut down just to improve the quality. I think we all can do better to do that, spending that time. And we all get bogged down with being busy with life, but be busy with doing better. And I think that improves you as a person, as a ritual. I think that's really good. And doing that, I think, by doing better involves fostering, cultivating a healthy level of skepticism. And and I think that's really, really important. And I'm not saying be negative and all of those things. Embrace what you need to embrace, but be skeptical about some of these claims that seem to be too good to be true. If something's too good to be true, guess what? It probably isn't. And in orthodontics, we've seen time and time again, not everything, but most things don't really measure the hype that was given to it at the start. And we sort of kind of get back to this, even keel. It sort of tapers off. And the science only comes up years later on. So be mindful of that. Don't need to wait for the science to come and tell us that was a ridiculous thing. You already got that information based on your experience and and what you're doing to be able to discern good from bad and something that's kind of off. So yeah, do better, foster a healthy level of skepticism, and use that quality education. We've all had a great education at university, a university level education. Use that, put that to good use, and really assess what you're doing every day as a clinician. That's my piece of advice.
Sanjivan, thank you so much for this really insightful interview. We've explored so many topics within OSA, and we've not left, I feel, any question unturned that I had, from the confusing literature, from also how to interpret the literature. And my real key take home message from your interview, amongst all the pearls that you've given, is the idea of critical thinking, right? We may not all be born with the same level of clinical practice and the same types of appliances that we use, but actually we all have critical thinking by the virtue of going through our training programs. And the application of that is something we should stick to until we get better information. Thank you so much, Sanjivan, for this amazing interview. And to the audience out there, please do subscribe and look forward to the next episode.
Thank you, Farooq. Thank you very much.